something?
Yeah, who's
Not
that?
yet, not yet, please.
Okay, we got folks coming in now.
No, I was just gonna say there's a problem with the link that was sent out.
Yes, ma'am. We realize that the passcode,
Yes, it's missing one
it was
number.
missing one number. Yeah,
Yeah, we realize that.
we just realized that, so we're trying to get the information out as quickly as possible. Thank you though for your observation.
That was a
Okay.
test to see who really, really wanted to be a part of this.
What what'd you say, Marvin?
I said that was a test to see who really wanted to be a part of this. If they figured a way to get online, we knew they
Oh
really
yeah.
wanted to be a part of it.
Yeah.
You may begin, Delray.
All right, so let's begin. Good afternoon once again, and welcome to our weekly uh, health topics under the umbrella of Hope Missions 360. We welcome all of you who are on the line right now, and there's more to come, I'm sure. We do apologize for the mishap with the printing on the flyer. Looks like the passcode was missing one digit. So we know that as you get the word out, you're going to be joining. And again, we do apologize for those who are coming in. And we, again, welcome you. We have an interesting topic for you this evening. So as you know, based on the flyer, we're discussing some relevant issues this evening. We have arthritis that some of you all are suffering with, or you know about a little bit about. We're talking about lupus, fibromyalgia, and gout. So this should be a good topic. So hopefully all those who need to hear it will be on. We thank you for your support, your continued support weekly, as we're down to twice a month now. Next week's topic will be sickle cell and cancer, and we have some great presenters that will be on again next week. Okay, so without further ado, I'm going to introduce our panel, our moderator for this week. That will be none other than Marvin McLean, and he will introduce our panelists. So, Marvin,
Yes,
you want to begin with prayer?
sure.
All
So
right.
let's bow our heads for prayer, please.
Okay.
Heavenly Father, we thank you so much for being with us. We thank you, Lord, for bringing together the voices of science and reason, and those voices that will bring a spiritual aspect as well. We ask, Lord, that you will inform our minds and our hearts. Help us, Lord, to be better people from having been here. Help us, Lord, to become more informed, and help us, Lord, to spread the information that we receive. Is my prayer, ask in Christ's name. Amen.
Amen. So,
All
Marvin?
right, so
Hello, good afternoon. Let me just disturb you 1 minute. What's the missing number? Is 07529?
There's one. Okay, hold on one second.
yeah, if you would already just type that into the chat so that people who are on it can give it to other
Yes,
people.
because some of my friends from St. Lucia want
Okay.
to follow because I have a friend of mine who's suffering from gout.
Okay, I'm
Okay,
gonna type it in for you right now. Okay.
Thanks.
You're welcome.
thank you. So today we have the privilege of having two well-learned people to talk with us about those issues, including arthritis, lupus, fibromyalgia, and gout. We have someone who has been with us many times, and we appreciate it, Dr. Dwight Dawkins, who is one of our go-to physicians about all things that have to do with health. And we have a special guest today, Monica Ritchie, who is a rheumatologist, Monica Ritchie, ARNP, who is a rheumatologist, and she will be able to give us the benefit of her specialized knowledge in this area. which we very much appreciate. And again, we want to thank you, as Delray said, for you being here. Do not forget that we are a nonprofit charity, and we always welcome you to support us. If you go to our website, you can find the ways that you can support us if you so choose. We never charge for anything we do, but we do appreciate your support. So right now, I'm going to turn this over to our experts so that we can learn a little more about our
Marvin, you didn't come through clearly. Could you do the bio for the first presenter, please? And then
Sure.
it's in your email.
Okay. Can you hear me okay now?
Yes, go ahead.
Okay. All right. So our first presenter is Ms. Monica Ritchie. She is a rheumatologist, and that is her area of specialty. And I'm sorry, Grace, I didn't get the email in time to read it, so my apologies, Monica, for not being able to give you a proper introduction, but I can tell you that
No worries. I am a nurse practitioner, and I've been working in rheumatology for about almost 20 years now. And may I share my screen? Can you guys give me share screen access?
Yeah. I think you have to
I got it. I got it.
Oh, you
Yep.
got it now? Okay.
Thank you. Okay, so it was a tall order. They didn't contact me. I was very happy to be speaking with you guys today. So I'm gonna quickly go over osteoarthritis, RA, and lupus, which is one of our more common rheumatology diseases. So OA is really the most prevalent, being present in about 35% of the population. Rheumatoid arthritis about 17, and then other about 10. And other can be anything from fibromyalgia to psoriatic arthritis and gout. Paraneoplastic syndrome is another one. Some people with cancer will first present as a rheumatoid arthritis kind of syndrome, but is one of the first symptoms of cancer. We also have Lyme arthritis for people who have Lyme. And then there is a very not well known, but people with diabetes can have their own special type of arthritis, which is called diabetic arthropathy. So osteoarthritis can really affect any joint in the body. And it's different than the other types of arthritis because it's more of mechanical. It has to be with trauma, overuse, or genetics. So if your mom, your dad, your grandfather, your grandmother had arthritis, you're more likely to develop this as you grow old. Obviously, if you're an athlete, if you're a runner, you're more likely to develop early osteoarthritis just because of the overuse of the joints. So knees are a big area for osteoarthritis. It's where we have the most ones. And here in these pictures, you can see the first pictures of a healthy knee, and you see the cartilage, everything looks good. You have the meniscus here, big and thick. And then when moderate RA used to come in, you start to lose cartilage. So this is the hallmark of the disease, is really the loss of cartilage. So the bones start to rub on the bones. So you have pain when you're moving that joint, and not so much pain when you're at rest, which is different than the other types of arthritis that we'll talk about it. And when it's severe, the cartilage is really gone, and all you have is what we call a bone on bone. right? It can happen, as I said, in the shoulders, in the hands, in the knees. A lot of people have it in the back. You have some stiffness, but it resolves quickly. And particular in the knee, people will say that my knee makes noises, right? So you go up the stair and you hear a crack, 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 crack. So that's a sign of osteoarthritis in the knees. Hands particular are very much affected by OA, and they have this knobby-like format that you can see here. So it looks like your joints are getting fatty, and you start to develop knobby fingers that we call here. There is some also atrophy of some of the muscles in the hands, because particularly in the thumb, people have pain. They tend to develop arthritis in that particular joint right here, and you start to use less, so you start to lose muscle. Very common in the back, where you have bone spur formations and where you have a nice fluffy disc when you're in 20s. When you get to your 40s, your disc is not as much fluffy anymore, and you start to have more back pain. Treatment of osteoarthritis is really symptomatic. We don't have anything that treats the disease itself. So usually we start with topical anti-inflammatories, right? Here we use a lot of diclofenac gel. We prefer topicals over oral. And then exercises, physical therapy. Any type of physical therapy for osteoarthritis includes building muscle, because that muscle will stabilize the joint. So, and if you're overweight, obviously you need to lose weight, particularly with the knees and the ankles, because they held most of your weight. After that, we go on to oral anti-inflammatories. It could be naproxen, your over-the-counters, and then we come into the intra-articular injection. So we start to inject those joints because it's really bothersome. It's interfering with the life of the patient. So the first one is steroids, which is cortisone. We don't tend to do it a lot. In the old days, that's all we had. So we kept injecting and injecting. And it's true that if you have a lot of steroids injection in your joints, it will start to damage your cartilage. And then now we have the hyaluronic agents such as Oflexa, Symbisk, and those you can have it if your insurance covers every 6 months. And they provide like a little cushion, a little lubricant to the joints. So it hurts less. And this is all like, it goes into like, as things get worse, you up a little bit. Currently, there is also something called PRP, which is platelets-rich plasma. Some orthopedics do that. It's a specific injection where they draw the patient's blood, spin it, take the platelets, and inject back on their knee with the hopes that will help form some cartilage of the patient. And then we're hoping that in the next few years, we're going to have more of stem cells injections that are covered by insurance, and then some other medications that will build cartilage, because your cartilage is basically gone. When we are born, our body loses the recipe to make cartilage. So whatever cartilage we are born with is the cartilage we're going to die with. So our body does not know how to make new cartilage. So a lot of the new medications are coming in trying to make a new recipe for you to make cartilage. Surgery is the last case scenario, and then sometimes they'll do arthroscopy where remove the loose cartilage, repair some tears, joint fusion, and then the joint replacement. As I said, non-steroidals have to be used very judicially, because over time, this can damage the liver and the kidneys. So you have some prescriptions, meloxicam, naproxen, Celebrex, over-the-counter. Some people tend to take a lot of over-the-counter, and it's very dangerous. The side effects, it can be a peptic ulcer, it can be a stomach bleed, liver toxicity. It interacts with a lot of drugs. It can cause hypertension. So we have to be very careful how much of them we're taking. And then we have the topicals, Bengay, Aspercream, Icy Hot, they're all great. Whatever works, it's fine to use it. And then there is natural remedies, because a lot of my patients are interested in that. So number one now is really the turmeric. We have a lot of evidence that turmeric or curcumin helps a lot. It's a very natural anti-inflammatory. The key here is that when you buy turmeric, it has to have black pepper in it. That's what activates the turmeric to become an anti-inflammatory. So Just the powder alone would not enough. A pill of turmeric will have the equivalent of a bowl of turmeric, so it's very hard for you to eat that much turmeric in a day. So I recommend my patients to actually buy the pill and take it 2 a day. Chondroitin, glucosamine, collagen, fish oil is great for the joints. And then as a topical, castor oil is really good for joint pain, particularly if you have hand osteoarthritis. Diet has a lot to do with it. So usually you have to eat a diet that is low in carbohydrates. Red meat cause a lot of my pain, and potatoes, believe it or not, will cause a lot of joint pain because it's highly inflammatory. There is a lot that we can do outside of medication. So acupuncture, physical therapy, chiropractor, ultrasound, TENS machine, heat and cold. There is more and more things coming in, particularly with Botox injections for people who have a lot of muscle spasms in their back, nerve trigger injections, epidurals. Those are all for people who have chronic back pain and suffer a lot with it. Moving right along, so a lot to cover. We're moving on to rheumatoid arthritis, which is very different than osteoarthritis, where osteoarthritis is really mechanic. Rheumatoid arthritis is really inflammatory. It's really truly your immune system that goes on, attacks the joint and destroys the joints. So when you're gonna have swelling, tenderness, so it's both wrists are gonna be swelling, both shoulders, both knees. Patients come in with severe swelling. They cannot move at all. They're stiff for hours, sometimes throughout the day. And if you don't treat it, what is gonna happen is it's gonna destroy that joint. There is more to RA than just the joints. It will affect a lot of other parts of the body. Eyes, lungs, hearts, they all can be affected by rheumatoid arthritis, so it has to be treated. Females always higher than male in rheumatoid arthritis, and is about a 2% incidence worldwide. When you get to the 40s and 50s, it's more frequent, but it can happen in children and it can happen in young adults as well. Lab work helps a lot to identify those patients, and sometimes, particularly when it runs in family, you can do the blood work and know if you're going to have this predisposition, because those labs, those blood works are actually present about 10 years before you actually develop the disease. We don't see a lot of joint damage, but it's happening as if you take 2 years, 3 years, and sometimes I see people coming in that just, figure out they can do it on their own and complete joint destruction. So if you're having any of those symptoms, go to the rheumatologist very quickly. So rheumatoid arthritis affects every joint in the body, the neck, the shoulders, the elbows, the wrists, the knee, the ankles, except for the lower back. It does not go in the lower back. So lower back pain is more related to osteoarthritis. So this is some of the extra articular manifestation that I was talking about with rheumatoid arthritis, where osteoarthritis is really just a joint. RA is a lot more. People can have heart disease from the inflammation of rheumatoid arthritis. It can affect the kidneys, it's kind of rare, pulmonary, eye, and also skin. In the old days, you will have the rheumatoid nodules forming into the joints. So this is just a quick x-ray. And what's happening here is, you can see here, it looks like there is a rat bite into that bone. So it's true erosion of the bone. It's really your immune cell eating away your bone. So it's not the cartilage that goes, but it's really the bone. And you can see some other parts here where you can see what we call it the little rat bites, where you can see the activity of the immune system. The bones and the wrists are almost completely fused. And if it's not treated, you will lose movement on that wrist. This is a typical hand of somebody who had rheumatoid arthritis for many years, and you can see that there is you can barely see the wrist. You have rheumatoid nodules forming. You have the deviation of the fingers and the hands as well, and you have this protrusion of the knuckles. They get very big in people with rheumatoid arthritis. Diagnosis is a little bit complicated. I'm not going to go over this, but there is a lot that goes on into diagnosing rheumatoid arthritis. there is two different criteria. But basically, we look at the laboratory, we look at the presentation, we look at morning stiffness, and how many joints are affected. So rheumatoid factor and anti-CCP are two of the most diagnostic labs that we have in rheumatoid arthritis. Inflammatory markers would also be present and highly elevated in people with rheumatoid arthritis. And why do we do that? Is just to confirm the diagnosis. Particularly in the United States, the insurances want to see that. And even though the rheumatologist can look at it and say, oh yeah, you have rheumatoid arthritis, I see in your joints, you still have to prove to the insurance company, and you want to make sure you're making the right diagnosis. Now, there are people that is not going to present with the lab. So they're cholesterol negative, and they make about 20% of people who present with rheumatoid arthritis. So it gets a little bit more complicated. The very expert, the experienced rheumatologist will pick it up either in an X-ray or in the presentation of the patient. But it's not because the labs are negative that is a completely, no, you don't have rheumatoid arthritis. There is a lot of medications that go on. So we start with anti-inflammatories, then a lot of cortisone, but it's short term. And just to bring down that inflammation, that initial inflammation that people come in. And then we have the older medications, methotrexate, hydroxychloroquine, leflunomide. So those are the initial medications, right? So you're gonna be on that for a year or two. And then since 2001, we have what we call it the biologics, and it's a large arsenal into rheumatology of, and the ones that you see in the commercial, adalimumab, which is Humira, or etanercept, which is Ambro. There's several different ones coming into the market. And they were a revelation for us because they really stopped the progression of the disease. So the old hands of rheumatoid arthritis, people who couldn't walk, that kind of like we rarely see those now here in the United States because we tend to use a lot more biologics. European countries tend to use more of the methotrexate and the hydroxychloroquine. They are cheaper, they're easily accessible. The side effects of the newer medication is really immunosuppressant and it's an infection. So we use the medications if we have to, but patients are monitored very closely just because of the risk of the side effects, but the benefits outweigh the risks on those particular patients. And there's a lot of education that goes in once those patients go on those medications. But treatment is important. It should not be delayed just because of the complications that you have from untreated disease. Moving right on to lupus. That's the most complicated of our diseases. It's basically 1,000 different diseases into one. There's different manifestations, different types of lupus. It's one of the most life-threatening of our diseases, and it affects from children all the way up to women at age 45 to 50. So there is many different types of lupus, difficult to talk about in here in 20 minutes, but it's just that makes it very difficult to diagnose lupus because of the difficult with the presentations that they have. What causes lupus? A lot of my patients want to know. We truly don't know. What we know is that mix of genetics. You have a predisposition to it, maybe down your grandmother or some cousin of yours. So you have some genes there. And then females make up about 9 out of 10 patients with lupus. So we have a predisposition because of our sex hormones, or estrogen and progesterone plays a role. And then the environment. And the environment is really the trigger. That's what really makes everything come together. And that could be an infection, that could be an antibiotic, that could be a medication, that could be pregnancy. Anything that stresses the body and makes your immune system hyper can trigger that. So it's really a perfect storm coming together. To diagnose lupus, you have to have at least 4 or 2 presentations out of all of those. I will quickly go over them because they're very disabling when they present very aggressively, and usually the younger the patient, the most aggressive the disease is going to be. So with kids, with teenagers, and young women with the age 20, you see very severe disease. Men is rare, is about 1 out of 10, but when they get it, they only know the severe form. They don't know mild lupus. So men comes in presenting with either what we call a lupus cerebritis, where the brain is affected, or kidney or heart. They come in with a very severe organ disease that we call. There's several different types of labs, and I see a lot of patients coming into the office with the ANA or the ANA, right? It's non-specific to lupus. It's very specific to to all autoimmune diseases, and it has an affinity for lupus, but a positive ANA does not give you the diagnosis with lupus. So I just want to, because people go to Google and they immediately think they have lupus, is not so easy, okay? There is a lot of other labs that go on diagnosing lupus, and we have to put the whole picture together before we can tell you there is lupus. But basically, more women than men, African-American, Hispanics, Afro-Caribbean, and Native Americans have the highest rate and the most severe disease. So they usually come in with organ-threatening disease, kidney, liver, everything with them is very severe, okay? And they usually have the worst outcomes as well. So we really have to monitor that population very quickly. There is a serious difference between Caucasian lupus and African-American, Hispanics, and Native Americans lupus. The second group has much severe disease. If you have lupus, my patients are always concerned, is my baby's gonna have lupus? Not that cut and dry, okay? So if you have a identical twin, the percentage that the identical twin is gonna develop lupus is about 50% only, so 50% will not develop. If fraternal, 2 to 5. If you have a daughter with SLE and you have SLE, your daughter has a 10% chances of having SLE, your son 2%. And if lupus runs in your family, sometimes it's normal for you to have lupus labs that are positive, but not have lupus. Can happen. These are some of the skin manifestations of lupus. You can see the malar rash here. It's red, it's very bright, it's painful, okay? They will say it hurts, and that's very typical of the malar rash, or we call it the butterfly rash. This is actually not a burn, this is photosensitivity. Lupus patients are sensitive to the sunlight. If they get in the sunlight, it's gonna almost look like they have a sunburn, and their disease is gonna become very active. They will have mouth sores that are not even painful. They don't even know it's there. And in children and in adults, we can have what we call a discoid lupus, which is a skin lupus, and it can cause severe scarring of the skin. You will see here, if it happens in the scalp, hair will never grow again. That scar will be there forever. Alopecia is very common. It's almost like if you have chemotherapy, your hair will fall off. That's severe. And you can have what we call vasculitic rashes, where you have this very red, bright, and tender rashes. You have this kind of lace-like skin changes, and you will see that in your hands, in your arms, in your legs. So this is all some of the skin manifestations of lupus. It can affect the bones as well, and in some people, it can cause what we call a vascular necrosis, where the bone actually dies from the inflammation. So those are all things that can happen. It can affect the lungs as well, and it can be as severe as a person needing a lung transplant. Very common is interstitial lung disease. It's an inflammation of the lungs, and much easier treated than if they have this kind of pattern where this is just like the lungs are gone, a severe fibrosis of the lungs. Cardiovascular disease is the #1 cause of death in lupus patients. So we have to be very careful with our lupus patients and their heart, particularly because it causes early heart disease. So you have 25 years old, 30-year-olds having heart attacks and strokes. And that's just because of the inflammation. So we have to monitor them very quickly. We have to always send them to the cardiologist to make sure their heart is nice and healthy. It affects the brain in many, many, many ways. We have a specific I guess, form of lupus that is called lupus cerebritis or neuropsychiatric lupus, where patients will really get very confused. They will reverse to being almost a baby-like, and those are very severe manifestations that have to be treated very aggressively. But anxiety, depression, and cognitive dysfunction, meaning memory loss, lupus patients will have severe memory loss to the point that sometimes they're unable to keep a job or go to school. So this is a very severe disease. It also can cause anemia, low platelets. This is all seen into the blood work, and that's why we always do blood work in our lupus patients, because we want to know how active that lupus really is. Lupus nephritis is the most common and the most also deadly one. 50% of lupus patients will develop what we call a lupus nephritis when lupus affect the kidneys. It's silent. They would not know unless they come to the office and do a blood test and a urine test. They will start spilling protein. The urine will become foamy, yellow. They will say smells funky. And sometimes they don't even know it if you don't have a very high level of protein. If it's untreated, it can cause death. So mortality rate is still very high, unfortunately. And the treatment is not easy. It can be either a lot of medications, and chemotherapy is also part of it. So particularly for young women, it's a very difficult treatment. It's a very difficult period. And they need all the support of the family and the friends, because it's really a serious manifestation of lupus. And is also higher in African Americans and Afro-Caribbean women than in Caucasian women. So we always watching them for that particular complication. The treatment of lupus is highly complicated. Many medications. I had a patient once for taking about 17 different pills a day. So it's very hard, and compliance is really key here because it's so difficult for you to take 1 or 2 pills a day. And if you're 20 and you're taking 17 pills, it gets more complicated. As I said, some of them will require chemotherapy, and the chemotherapy that we do for lupus patients can cause infertility. So it's something delicate that you have to talk to the patient, and they have to have the support, and the patient needs to understand why it's needed, because if it's not treated, it will lead to death. Pregnancy, and this is my last slide. So a lot of people think that lupus patients cannot have babies. Yes, they can, if the disease is in remission for at least 6 months to a year. There has to be complete remission. That patient has to be really well monitored, really well controlled for that patient to have a successful pregnancy. Pregnancy can be fatal in patients that are not controlled. It can lead to severe lupus flares, hypertension. Preeclampsia is very common. Maternal infections, pregnancy losses, preterm babies, small babies. So there's a lot of complications for all the women out there that have lupus and want to have a baby. Get your disease under control. It takes time, and it takes compliance, and it takes a lot of strength on your part, but it's possible. And then when that disease is well controlled, you can have a baby. And with that, quick word on vaccinations. Vaccinations are important. We do hope that our patients do get vaccinated. They cannot have any live vaccines, but they can have all the other vaccines, such as the influenza, the Hep B, the HPV. HPV is very common in lupus patients. They cannot clear the virus, which can lead to uterine cancer. So it's important that they receive those vaccines. And I think that's it. And I really thank you for being here and having me.
Marvin? Thank you, Dr. Ricci. That was very informative and excellent presentation. So if you can,
Yes, it was.
You're back, Marvin?
Can you hear me now?
Yes.
Yeah.
So
okay, so thank you very much. That was Monica Ritchie.
ARNT, and we thank you so much for the information. So one thing that I wanted to point out, these groups of diseases, including gout and rheumatoid arthritis, psoriatic arthritis, all those fall under the category of arthritis, correct?
Yes, it's a big umbrella, and there is a lot of diseases that go under that. But gout arthritis, psoriatic arthritis, rheumatoid, osteoarthritis, they're all arthritis.
Okay, very good. And then when you're talking about the NSAIDs and the cortisone injections, people still use those, but they have to be used with care. Is there any guidance that we should make sure people have in terms of making sure they don't take too much of these medications?
Sure. With the Tylenol, which is the least effective for osteoarthritis, but if it helps, it helps. So it's usually no more than 4 tablets a day. So it's the 500 milligram acetaminophen or Tylenol that we're talking about. So we're talking about you can take 4 tablets a day with no issues. If we're talking about over the counter, you can take like 2 Aleve a day or 4 Advils a day, but I wouldn't say every day, because every day will really long-term lead to liver and kidney issues. So it's really that day that you're going to do a lot. You going to clean the house, or you're going to go out with the kids, or whatever you're going to do that you're going to have a lot of activities. That's the day you take it. You can take it before and after your activity, so you can do what you need to do without a lot of pain. But every day is not recommended. In some cases, particularly people who have severe osteoarthritis, there's nothing to do. Then we do give them like daily NSAIDs, but we monitor them very quickly. We'll do blood work to make sure that kidney is not being affected or that liver. But I would not pass any more than 4 Advil a day, and that's the over the counter. So it's about a total of 800 milligrams of Advil a day. And also in the elderly, that becomes problematic. So in the young people, 800 milligrams of ibuprofen is okay, except if you have a kidney issue. But in the elderly, that it's even less. So we're talking about even half of what, maybe 2 Advils a day, 1 Aleve a day, 2 Tylenols a day. They have much different metabolisms, so they need less medications in their system.
Okay, thank you very much. Very much appreciate that information. So right now we're going to, sure,
okay,
go ahead.
I got a quick question. Doc, before you go, I just want to know as a Caribbean individual, what are some of the natural remedies that you can use away from taking Tylenols and all of these over-the-counter tablets that can help arthritis?
So turmeric is one. It's the only big problem with turmeric is that sometimes can upset your stomach, but it doesn't really bother your liver or your kidney. And it's about a total of 1,500 milligrams a day. That's number 1 right now. Then glucosamine chondroitin really helps, and that's another one that really doesn't have a lot of issues with liver and kidney. So that is like all kind of natural supplements that you can do. Collagen is another one, and the biggest one is really omega-3 or fish oil. The problem with the fish oil is to really get to the joints, you need to be taking about 4 fish oils a day, which sometimes can be very hard on the stomach. And sometimes I tell my patients just to take the krill oil, which is a little bit more tolerated. But overall, those are the most common natural remedies that we use here, that we have access here in the United States.
All right, thank you very much for that. Right now, we're going to ask Dr. Dwight Dawkins to join us and give us the benefit of his information. Dr. Dawkins?
Marvin, before we go, Dr. Ritchie, she's still sharing her screen. So if Dr. Dawkins has something to share, she's probably going to. There you go. Thank you so much. All right, go ahead.
Thank you, and thank you, Doc, for the excellent presentation. Couldn't follow in that type of shoes. But I'm going to talk a little bit about, gout. I'll start with gout, which, the question was asked earlier. Gout can affect both male and female. Men seems to be more affected by it. And, there's certain things, of course, that can trigger it. Certain foods, high protein food is, known to trigger gout. There's certain types of cancers also that can trigger gout. People who have like lymphoma, leukemia, multiple myeloma, that can also trigger it. Gout is a deposition of crystals in the joint. So you find that it's inflammation caused by uric acid that's going into the joint, or urate going into the joint, and then the inflammation starts. You get redness, swelling. The most common area that people talk about usually is the big toes, any one of the big toes, but it doesn't have to be. And also it can affect multiple joints, but it's usually not symmetric. You might find that, one knee may get it one time, and then after a while, the other knee may get it on a different occasion. Usually comes on very rapid, not associated with any type of trauma. All of a sudden you wake up, or, say, man, my toe is bothering me, or my knee is bothering me. It's swollen, it's red, warm to touch. And of course, there's nothing to indicate that you had an infection or you didn't twist it and didn't do anything. And it's there. Because of the swelling, you might feel some stiffness, and you're not quite sure what exactly is going on. The best way to diagnose it actually is just to get an aspirate. If somebody puts a needle in there, draw it out, and then send it to the lab for evaluation. They'll find the crystal and can say, okay, this is exactly what it is. You also have a condition called pseudogout, which presents somewhat similar, but it's another type of deposition that causes that. As I continue, probably the best way to describe treatment options in any of the arthritis, including what was stated before, the rheumatoid, the osteo, there are three types of general treatment options. And if you remember this, you can actually then decide, of course, when to go to the doctor to seek help, and what exactly you're expecting when you get to the doctor. The first big category is, management of symptoms. It doesn't matter where the pain is. The management of symptoms is one of the first things. If it's pain, you want to be on some sort of anti-inflammatory that reduces the inflammation and then decrease the pain. Or something like Tylenol, which is not an anti-inflammatory, but it's an antipyretic that will help with the pain as well. If there's spasms of the muscle, sometimes with osteoarthritis, you might end up having muscle spasms, especially when it's in the spinal column. People complain of pain, in the side of the back and not necessarily in the middle. So sometimes, in addition to pain management, you might need muscle relaxant to assist with that. And then another big category would be physical therapy, which was also mentioned. Physical therapy includes exercise, stretching, particular to a specific muscle to help to build, and as was stated, to help to protect the joint itself. And then the last option for anything that has to do with joints and arthritis would be surgery. And that could involve many different things. Even sometimes people with bad rheumatoid or bad osteo, they either get a joint replacement or get something to stabilize it. They do these things to help to release the pain, and also to sometimes give some functionality to it. Sometimes the function is really just, if the body is very contracted, they might do surgery just to release the tendons so that, the pain from the contraction or the harm that may be done by the contraction is released. And when I say harm, I've seen people so contracted that the nails, puncture the skin, or if it's in a position for too long, you end up getting skin breakdown and that type of thing. So when you think about the main categories, and included in that also, I would say chiropractor tends to be a little bit of the physical therapy type of modality. Cortisone injection, sometimes they'll do injection that has to do with the medication part of it, the pain management and the decreased use in medication. So when somebody comes in to the office and they're saying, I have this joint pain, or, my back is hurting me. And they come in with the expectation sometimes of, wanting relief, but not necessarily sure of exactly where they're going. They don't know whether they need an X-ray, an MRI, or what it entails. Treatment of these pain may it could accumulate to a lot of money. So I usually start from telling them what the options are, those 3 general options, and say, let's work backwards now to see where we are and what we need to do. Most people, when they come in and you say, okay, these are the 3 main options. What do you think, or which class do you think you fall in? Once you mention surgery, they'll say, oh, no surgery for me. Because most times they're not in that level of pain and they're not that distraught or limited. So once you take surgery out of the picture, then you're left with pain, symptom management and physical therapy. Well, those you're going to do regardless, meaning, you're going to address the pain and you're going to recommend some sort of therapy, physical therapy, or, some sort of exercise. And so with that, you realize that you can actually reduce the amount of imaging that you're going to need. So if we're not going to do surgery, then there's really no need that, you go through with the MRI. You can do it, but that's just for, knowledge sake, but you're not going to necessarily act upon it. Now, of course, if there's something serious, such as, limitation of walking, all of a sudden you get some numbness and you're not quite sure, then you can order it. But again, if you're not going to do surgery, again, you can work with symptom management and the therapy. And those things you should actually, as far as the physical therapy, that's exercise. We should always be doing exercise, aerobic, and also some muscle strengthening. Those things help. So going back to gout, as we were talking about, the treatment is going to be anti-inflammatory, the same anti-inflammatory that we use for all the other conditions, as mentioned earlier. Sometimes we may use steroids. And then there are medications that are used to actually decrease the amount of uric acid that is being produced or in the body, or that's circulating, so as to urate, so as to decrease the precipitation of the crystals into the joint. And you can affect that by many different ways. Colchicine is one of them that have been used over the years. The interesting thing with colchicine is that it was very cheap at one point. And somebody decided that, as they researched, they realized that nobody actually got the FDA approval. It's very ingenious, but it's really highway robbery. Colchicine was around for many, many years. Somebody said, wow, they didn't get the FDA approval. And so they went ahead and used the same medication, got FDA approval, and then restricted it from use for anybody. So all of a sudden, the price, being pennies, went very way up because now they had a patent on it. But nevertheless, it's something that's worked, and throughout the world it has been used. You have other things like allopurinol that is also used, as far as treatment of it. And there's some new medications that have come out. I'm hoping that the rheumatologist is still online. She can probably speak to that, because I know that there's somebody specifically was asking about gout. Moving right on quickly to another topic is fibromyalgia.
Dr. Dawkins, can I interject one more thing?
Yes.
Just to let our participants know, or to remind them, that you can ask your questions in the chat. I don't see where questions are coming in, so you all probably have forgotten. So if you have any questions for Monica Ritchie, our nurse practitioner, or for Dr. Dawkins, you're welcome to put them in the chat, and they can monitor those, okay? All right, thank you. I apologize. Go ahead.
No, thank you. All right, so so there's another condition that to be mentioned, and that was fibromyalgia. Now, fibromyalgia is a very interesting disease because it hasn't been around for very, very long. I mean, as a matter of fact, I think when I was in medical school, it probably was just coming into its own as being defined. It says about 2 to 8% of the population suffer from this condition. It runs in family. 41% of the time, you might find family members that are affected with this. They're not quite sure exactly what the problem is that caused the condition. And so it remains a clinical diagnosis. We know based upon the medication that is used to treat it, that it seems like there's something going on with some of the hormones that's produced, in the brain, for instance, the serotonin, the dopamine, and also catecholamines. Something is going on because the medications many times seems to help, but we can't actually define what it is. It says about 15 to 30% of the patients who have this condition also suffer from other criteria that may be common with other illnesses, such as IBS, irritable bowel syndrome, or TMJ, chronic fatigue. So you have a person that comes in with a very non-specific type of complaint. They're complaining about pain all over the body, diffuse tenderness. You touch them at certain points and it's painful. You don't necessarily see any swelling in the joints or any redness, but it's tender to touch. Fatigue that is unrelieved by rest, greater than 90% of the time, you find that people will complain of that. There's also sleep disturbances, where they're not able to sleep as well. And it's not due to any other condition such as sleep apnea or a restless leg. Then there's also mood disturbances. Question which came first. Was it that they were depressed and the issues came on, or was it because of the chronic pain and chronic limitation that they're now depressed? So that's a big thing. Cognitive function, they tend not to be able to focus as well. Numbness, tingling, sometimes other neurological complaints. The diagnosis is straight clinical, even though when the person comes in, you'll tend to want to do a bunch of workup just to make sure that there's nothing else physical that is actually contributing or causing the problem. So they'll do a SED rate, for instance. A SED rate is a non-specific test that tells you if there's some sort of inflammation going on in the body. Could be arthritis, it could be cancer, could be an infection. And so you do this test, and in a person coming in with fibromyalgia, the test is normal. You check to make sure they're not anemic. You check to make sure that they're not hypothyroid. You check to make sure that their vitamin D level is up. And all of these things tend to come back normal, yet the patient is giving you and telling you, how they're feeling. And, on physical examination, they're reacting to it. And so you find that it's, one of those difficult conditions, I wouldn't say to diagnose again because it's clinical, but as far as treatment. And so you find that you end up treating symptoms, the pain, you end up treating the sleeping problem, and you give them medication sometimes to try to stimulate them. And there are other conditions like this, polymyalgia rheumatica. If you actually go into the variety of different conditions that entail arthritis, as stated before, it's many. The one that's most common, as mentioned, was the osteoarthritis. That's wear and tear, and that you can understand. The more active you are when you're younger, the more likely your joints may pay for it when it's older. The good thing with that, I tell people, is that, listen, if you live to get arthritis, then, you're likely not one of them that will drop dead from, for the most part, early from heart disease. So you exercise, it builds the heart, but you're going to pay for it, later on. And, there are other things. Sometimes the body, one of the things that was mentioned with rheumatoid and psoriatic, the body's immune system is acting up on itself. And the medications that were mentioned are medication that decreases the body's ability to respond, not just to the inflammation, but also to the infection. So at this time, I'm going to give time for questions and answer. I think the doc before me gave a very good, comprehensive, lecture on exactly what arthritis is. And as a matter of fact, just to mention this, anyone with rheumatoid arthritis that's reached a certain age, 65, Medicare, the Medicare requirements are actually wanting the doctors to make sure that they're seeing a rheumatologist to be on medications to treat that condition. It's actually one of those things that they check primary care to make sure that your patients are on some sort of DMARD or something to control the rheumatoid arthritis, and that's how important it is as far as management. Well, thank you very much for having me.
Thank you, Dr. Dawkins. So we'll go to questions. And just so you know, I failed to give this information at the beginning. I'm going to just give it now. Dr. Dawkins has been in medicine for 20 years. He's a graduate of the University of Miami Miller School of Medicine, and he completed his residency at the in family medicine at the University of Florida North Broward Hospital, and he currently practices in Port St. Lucie, Florida. And he's passionate about God, and he wants to be God's hands and feet, the hands and feet of Jesus. So thank you very much, Dr. Dawkins. And then Sister Monica Ritchie, your sister now, Monica. So Sister Monica Ritchie has been a nurse for 18 years, and 15 of those have been in the field of rheumatology. And she received her training at the Hospital for Special Surgery. And she's passionate about patient education and has herself developed several different patient education programs, including some for cardiovascular disease prevention, contraception, and preventative health. She's part of the steering committee for the Rheumatology Advanced Practice Providers, and she's a patient advocate and has participated in multiple Washington, D.C. Hill meetings alongside patients and providers. And she's currently working as a nurse practitioner at the Division of Rheumatology at Northwell Health in New York. So thank you very much. We're very privileged to have you with us. And we hope that you come back again. And we thank so much. I believe that you were invited here by Nadine Spring. And so we thank you, Nadine, for inviting Sister Ritchie to be with us today.
My pleasure. You're welcome.
All right, so on to questions. So we had one question to pop up. One person apparently has a question about a different medicine. Their doctor has them on so many meds, and they want them to now try Enbrel. So can either of you give us more information? Do you know anything that we can give this person about Enbrel?
Sure. So Enbrel is on the category of the biologics. So Enbrel is one of the oldest, what we call it biologics, meaning they really work in the immune system to stop the progression of the disease. The side effects of the Enbrel is that it lowers your immune ability to fight an infection. So risk of infection is about anywhere from 0 to 20%. It's not a complete immunosuppressant, and people usually get really, particularly in the time of pandemic, get very worried about that. The most common infections that you will have is usually an upper respiratory like sinusitis. Pneumonia is last, is about 5%. Usually when we put patients on Enbrel, which is a great medication, we use a lot here. After you try all of the older medications, methotrexate, leflunomide, hydroxychloroquine, that's the next step. So it's just a matter of you really be on the lookout for any possible infections. So I usually tell my patients, you start sneezing, I need to know. You step on a nail, I need to know. You're not gonna call your primary care, you're gonna call me, because we usually treat very quickly with antibiotics. We don't wait. But overall, the most common side effects actually of Enbrel will be maybe a headache, which is more common than the infection part. But again, it's just the constant policing because of the infection risk. And I don't know what's your experience, Dr. Dwight, in the primary care with those patients as well?
No, I think most of the time it's just, we normally rule out, any TB or anything like that before starting them. Most people really don't have the, how would I put it? They don't have the means. You have to actually have insurance, and pretty decent insurance, yes, to be able to afford any one of those, type of medication. And so, if the doc is recommending it, is because it's at a point where we know what the future of untreated, rheumatoid arthritis will end up being. And as I said, that's why I think the government has kind of made that initiative that if either primary have a patient and they're not on the appropriate management, it's not considered good practice type of thing. So as stated, you send them to the endocrinologist, not an endocrinologist, the rheumatologist for continued management and monitoring.
Thank you both for that. So what I got from both of you is this is a very aggressive treatment. It's not just something that's not the first option. And if you're placed on that, it needs to be monitored very closely. And you have to stay in close contact with your practitioner if you're on it. So hopefully that answers the question. Got another question in the chat that says, fish oil, ginger tea, and exercise has helped my friend with an arthritic shoulder. Is that okay?
Yeah, I mean, if it's helping, it's fine. I mean, as I said, omega-3 fish oil, exercise is great. It's hard. People don't believe that your joint hurts and you have to exercise, but it's true. And in the end, will make it, the less you move, the worse that's gonna get. So exercise is really good. Physical therapy, any kind of exercise you can get in. If you have back problems, usually yoga and Pilates are the best. Ginger tea, I heard from my patients too that they do the turmeric, ginger, and that really helps.
Thank you. Anything to add, Dr. Dawkins?
Just keep in mind, as I mentioned, the three modes of treatment for whatever arthritis you have is symptomatic management, which that would fall into place. But working, you've basically taken the steps, and you don't need to go further. The physical therapy or the therapy portion of it, you do by default. I mean, the reason why you were concerned about the pain is because of the limitation that it may have. And then of course, surgery wouldn't even have been an issue.
He thinks he's more important than everybody else. He should not respect
anything. So if you could, Nikki, if you would put your phone on mute, we'd appreciate it. Thank you, Nikki.
Yeah. In respect.
Okay, Nikki's not listening to me because she's talking to somebody else, but we can hear your conversation, Nikki. So, Dr. Dawkins, did you complete your thought on that?
Yes.
Okay, thank you very much. I have another question. Can
I have one more thing just to add. Sorry, Marvin. That any supplements you take, you should talk to your doctor just to make sure you would not interact with the other medications. So anything that, and I have my patients who share things with their neighbors, it's a common occurrence. Just tell them, hey, I'm thinking about starting this. Is that okay? Would that be okay with the medications that I'm taking? So just be aware of that.
Yeah, good point. And that's any supplements that you take, not just the, certain ones, any of them. Okay, very good. Thank you. So there's a question, and I think I heard you answer this one earlier. Can osteoporosis cause arthritis in the lower back?
So
go ahead, Dr. Dwight. I'll let.
Yeah, so osteoporosis is thinning off the material that makes up the bone. So the bone becomes weaker. One of the things that happens as the bone becomes weaker is that it's prone to fractures. So many times people will come in and they have an acute onset of back pain, very severe. And when you do it, you realize that it's because there was a fracture in the bone, and it ends up being the cause of the pain. Of course, if it occurs close enough to where the nerve is, then you could end up compressing the nerve. And a lot of times people maybe just lifting their regular stuff. You went to the grocery, you're up in age and you're lifting, and it starts. So it's not due to inflammation itself, which is what osteoarthritis is a component of, both inflammation and the trauma of the friction, the weight weight. It's basically a lack of like vitamin D and a lack of calcium that's helps the bone to remain sturdy. So there are two different entities. As a matter of fact, for a general rule, and it's not conclusive, a person who is very active and does a lot of lifting, bodybuilders, for instance, you'll find that many of them will end up having osteoarthritis just because they're lifting weights or running all the time, the pounding of the joints. But those folks will tend not to have as much osteoporosis, because the body is made in such a way that when you use things, it keeps it stronger, it builds upon itself. So exercise is one of the ways that, to actually help not to have, osteoporosis. And exercise in the sun, not necessarily direct sunlight, because you don't want to have skin cancer, but getting out enough sunlight to be able to, give you vitamin D, to be able to do the whole process of keeping the bone strong.
Very good. All right, I guess I'll stop sun tanning then. Thank you, Doc. Appreciate that. So someone asked this question. Let me give this question in the chat first, and then I'll let you go. I'm developing a painful spur in the base joint of the ring finger on the right hand, and manifesting itself in the palm of the hand. What is the treatment for that, and is this arthritis? So one disclaimer before you answer, the doctors are not here to give diagnoses for specific conditions. They would have to examine you, but they can give you the benefit of their knowledge of past experience. So tell your lawyer they did not try to diagnose your condition, please. Go right ahead, Doc or Monica.
It's hard to say, right? Because it could be so many things. I think that the first thing the person has to do is to really go and have an x-ray. If she really had an x-ray and it showed there is a spur, then it's probably osteoarthritis. It's hard to see in the palm of the hand. So sometimes you can have tendon issues that feel very tender, and it can feel like almost like a spur, but it's not a spur. So I think the first thing you need to do is to go to your doctor and get an x-rays and get an exam. And sometimes you can have even what we call it a ganglion cyst in there that can almost feel like it's a spur, but it's not a spur.
Or the Dupuytren's contractor.
Yeah, exactly. The tendon, yeah.
And that's when the finger tends to be drawn down towards the wrist.
All right.
I got a quick question for Dr. Dawkins.
Go right ahead,
Dr. Dawkins, I appreciate you coming on. My wife constantly forced me to take calcium tablets. I do not like drinking milk. What are the alternatives?
I'm sure there's certain foods that has calcium inside there. Our diet, really, we get enough calcium just from our regular eating. It's usually not one of those things that we lack or complain about. Even with a strict vegan diet. That's not usually one of the things that we get. So there are many juices. Like you drink orange juice, you'll find that it's supplemented with calcium. Many of the other things that if you look at the ingredients, you'll see, calcium being part of it. There's some people, sometimes we use it to our advantage. Like there's some people who they have, heartburn or issues, and they say, you know what? Drink some calcium to settle your stomach, or eat some chalk. That you'll get calcium by that. So there are other means that you're going to get calcium, and I'm almost sure that you're not calcium deficient, because even the elderly who don't eat that well, when you do their regular blood screening, calcium is not necessarily one that they're deficient on many occasions. But when you do have osteoporosis, or osteopenia, then the supplemental calcium or having at least a certain level is recommended. As I said, looking at you, I doubt you're going to be deficient in calcium. So.
Thank you, Doc.
Mm-hmm.
Well, thank you very much. I'm glad you didn't advise him to get another wife. So this is why we have experts on, so we can get advice.
Hello.
Thank you, Doc. Appreciate it. Yes.
Hello, I have a question.
Go right ahead.
I have a question. Can you hear me? Okay.
Yes, loud and clear.
I have listened to the three people who spoke, and they talked about inflammatory disease and the process, and most of it has had to deal with medications. I have not heard one of the three people spoke about what is the true cause of somebody having an infection, this inflammatory process. And I've heard nothing about addressing the diet. All we're talking about is prescribing medication, take this medication, and then you take one and it doesn't work, you add another medication on. So how do you advise your patient on a nutritional diet that can help them eliminate some of the symptoms rather than adding another medication? Because in my sphere of work, I'm a nurse, I have a PhD in public health, so I do a lot of research. And for me, the more we use medication, the less we understand how our body works. We're not talking about nutrition. We're not talking about the 8 laws of health in order to heal our body. We're talking about medication more than anything else. How can we address patients when they come in? Look at what they're eating. There are certain foods that aggravate the symptoms. And I've never heard, I have lupus and I've gone to my doctor. I don't take any medication whatsoever because I control my health. I'm not going to let a doctor dictate to me my treatment modality. So therefore, my question to these guys is, how do you talk to your patient about what else can they do apart from, I'm not saying get rid of your medication, but apart from just the medication, how do they look at their nutritional status? What are they eating that is aggravating their symptoms?
All right. So we did mention some of that. It's just a matter of trying to decipher or go through it. And I'll tell you where it was mentioned.
Just a minute. I think you talk about supplements like turmeric and stuff, but the food we eat, the food we put in our system is what's killing us.
All right. So let me go ahead. And I used the example when I spoke about gout, and I mentioned that the meat. I believe I did mention that that increases the protein, and anything high in protein like that, of course, will cause more crystals to basically become in your body, and that will cause a problem. Now, as far as breaking down the cause, you have osteoarthritis, which is the number one. That's a matter of wear and tear. That's a matter of usage. So you find that the best way to deal with that, of course, is to maintain a normal weight, or if you're overweight, to lose the weight. So that entails, of course, diet and exercise. Exercise is important because, of course, even though you're limited by by the wear and tear and the bone on bone, if you stop using it, eventually it seizes up. One of the best examples is that there's a car that old car that if you don't crank it and start it, after a while, not even the best mechanic can get it to start. But as long as you keep on using it, it'll continue to work. And so it is with the body. So you find that the diet, and so whatever it is to bring your diet down. Now, definitely a whole nother aspect of diet is the things that are inflammatory. Again, a lot of the meat products that we use, those would be, causes inflammation. The way it's prepared, if you barbecue it, you end up getting less fat in it, but then you're also creating a lot more free radicals. Now, the reality is that most people who, when they come in to see the doctor, and especially by the time they reach the rheumatologist, most of them, the disease process has already started. And I should also mention that it's not always because of a poor diet or something the person does why they end up having to deal with the condition. As mentioned, a large proportion of these things can be hereditary. And hereditary, the Bible says, the sins of the father upon the children to the 3rd and 4th generation, meaning there are some things that pass down through the lineage, certain things that we are prone to. And unfortunately, most people, not like yourself, and not like most of the folks who purports to follow a certain religion, but most people don't care about making lifestyle changes. They care about treating symptoms. They care about being able to take away the symptoms so they can continue to do what they want to do. You're correct in that a lot of physicians don't spend time in teaching lifestyle change because they realize the resistance of people not wanting to change. I.e., you could take the matter of smoking. How many people continue to smoke despite the fact that we tell them that, you know what, this is harmful to them. So in essence, people are coming to you. You can spend 15, 20 minutes with the patient trying to advise them and to change their lifestyle, or you can make your own life easy and say, all right, fine, this is the prescription, you know, have a nice day, come back if it doesn't work, and we will deal with it. So what I would advise the people listening is that if you are concerned or if you are motivated to make changes, I wouldn't even tell you to seek the medical doctor for the information for that, because the reality is that you probably know more about the specific.
Absolutely.
Right. So you can either Google it, you can find a nutrition to deal with, but the medical doctors, most medical doctors, they're going to give you what FDA, gives as far as it's okay to use for that condition.
So I just want to add a few things, and I agree with everything that Dr. Dawkins says, particularly with autoimmune diseases. So in the beginning of my talk, I did talk about diet. I addressed that some foods are highly inflammatory, particular carbohydrates. So for my patients, and as he mentioned, some patients just want the medications, don't want to do the work. But I have patients who I really want to diet. So then, I can only point the little we know. I am not a nutritionist, but usually for autoimmune diseases, they have what they call the autoimmune diet, which is a very restrictive diet, which basically cut all gluten, all meat, all dairy from your daily food intake, and basically leaves you with vegetables and fruit. I also think that diet plays a huge role in developing an autoimmune disease. And I don't know if you remember when I was talking about lupus, on that perfect storm, the environment, our food is in there. There's a lot of things that is in our food that we don't know about it. So I am a firm believer in diet. I have patients that decided not to go the route of the medication and really try to do diet. But you have to be very strict and you have to be very restrictive, which sometimes is very difficult. So I have very few that actually succeeded on doing that. I have like literally 3 of all of my patients who actually decided to go that route. But absolutely, you are correct. Diet is important. I believe that we are what we eat. And in the world where, there's so much processed food and ready to go food, the natural aspect of it falls apart. So yeah, you are correct.
Okay.
Thank you very much. Appreciate that. And for the caller, someone suggested if you may want to share with us how you've managed to stay off medications, what's worked for you. So if you put that in the chat, we appreciate it. We've got 70 some people on the call, so we don't want to take up a lot more time on this. So
no, because my story is long. So if they want to call me, I could give them my number. They'll call and they could call me, because I went through the hair, even the flow. And I literally tell my doctor, no, you're not going to control me. I'm controlling me.
Okay. Yeah, if you put your number in the chat, then that would be.
I'll put my number in the chat. They could call me. I tell them how I do it, how I go about it. I don't let doctors dictate to me. Like recently, I'm here in Georgia, and I recently just got a rheumatologist because all my doctors are up in New York, and because of COVID, I'm not able to travel. And the first thing she asked me, are you on Plaquenil? I said, why do I need to be on Plaquenil? She couldn't give me a good example. I said, no, I'm not on Plaquenil, and do not prescribe it because I'm not taking it. I'm not on any medication. My blood works are okay. So therefore, yes, I'll put my number in the chat. Anybody could call me and we could chat.
Thank you so much. Appreciate it. And by the way, diet is so very important, but someone else says they kind of take exception to the question because they eat really well and sometimes still they have body aches. So, all of our bodies are different. So one thing isn't going to necessarily be the same for others. So you can eat really well and still end up with problems. So just thank you for that, Flory Debris, for giving us that. So we have another question in the chat. It says, does sciatica pain lead to arthritis? And so you can just give a short answer because I think I know the answer to that.
All right, so sciatica is the nerve being pinched in the lower back, in the lumbar spine, lumbosacral spine area. And
right.
that could be trauma, that could be from osteoarthritis, so, just lack of the cushioning in between each spine.
Okay.
Arthritis develops typically when people change their mechanism of walking. So you'll end up getting arthritis in the hip and the knee just because of how your mobility. If you're not, the body is symmetric and then there's a balance to it. And so when you're trying to overcompensate for one thing, then you tend to put more weight on one side, and that's typically how people end up getting the arthritis in the lower extremity. The one that's doing the more of the work because you're trying to compensate or provide relief for the other side.
Okay, thank you very much. I have another question, and this one is about the recommendation for fish oil. Someone wants to know where can they purchase vegan fish oil. So I think I'll take this one. If it's fish oil, by definition, it's not going to be vegan. There are other omega fatty acid pills that you can get, and you can get those from a lot of places, GNC, Amazon. Those are good places to look if you're looking for the other omega fatty oils. I have another question from someone. So Dr. Dawkins, you mentioned an excess of protein. How about a vegan who makes sure that they augment their diet with additional protein, plant-based proteins? Are plant-based proteins also implicated in gout and some of these other diseases, or is it mainly animal proteins?
Yeah, it's not. No, so plant-based is not. It's animal, and as I said, red meat is higher than than others.
Okay. All right. Thank you very much. I have a question. It says, I'm elderly, and when the temperature drops, my rib cage hurts. What do you recommend I do? So I'm assuming this person thinks that may be arthritis as well. So any recommendations for this elderly person?
Move to Florida. It gets cold. I'm making light of it, but if changing certain positions or making certain adjustments will relieve the symptoms, then for the most part, that's what you want to do. The rib cage, that's you're feeling pain when it fluctuates with certain temperature. It could be something just as arthritis, as well as you probably want to get some testing to make sure it's nothing like a bone tumor, multiple myeloma. Sometimes that can start off by just a little bit of pain, and then when you find out it's due to something that's actually more serious than that. But I would just avoid the inciting agent that is going to cause the discomfort.
All right, thank you very much. And Joanne says, not Florida, go to Jamaica. So thank you for that, Joanne. Appreciate that advice. All right, are there other questions from the callers that are not putting their questions in the chat? If not, I think that we will bring this to a close. I'm going to ask.
We have a question from Flory Debris.
Okay, go right ahead.
Oh, he raised his hand. I guess he.
He said, how can you diagnose arthritis in the hip? Yeah, so
MRI.
Yeah, so you do scans, to diagnose it. I mean, X-ray. Most insurance will require an X-ray first, and then typically for the joints, MRI usually gives you a better picture. And except if you have something metal in your body, pacemaker stuff where you can't do it, then they'll do a CAT scan. But most arthritis, rheumatologists like Doc who was online, they can basically tell you from your history what the suspicion is. And, you know, most times they will actually correctly diagnose you the most common causes. You know, it's osteoarthritis, you know, but an X-ray is simply what you would need to just confirm that.
Yeah, I agree. We usually use the x-rays first, and then we follow by MRI as needed. History is important. So, and a lot of people confuse the hip with the back, right? So the hip is really when you have pain in the front in your groin, and then, you know, what we call it, you know, particularly the Hispanics call it the caderas, is the lower back. So if it's in the front, it's the hip. If it's in the back, then is the lower back.
Very good. Thanks very much. Any other questions before we close?
Marvin? Oh,
Yeah.
yeah, it's me, Del Rey. Before we close, we just wanted to just highlight some announcements. I can go ahead and do it, and then I'll turn it back over to you.
Go right ahead.
Again, we want to apologize for the mishap with the passcode. Hopefully everyone got on today that wanted to, and that you you know, you learned a lot this evening. So again, our sincere apology about that. We also want to announce that you can find us on Facebook, like us on our Facebook page. This seminar has been recorded, so you should be able to go out there and see it. It's under Hope Missions 360. You could also subscribe to our YouTube channel, and the support of our mission, of our ministry, which is of course Hope Mission 360, is well needed. So we're accepting donations on our website, and we hope to be able to continue these educational and informative webinars with you guys. So our topic next week, as I indicated earlier, is sickle cell and cancer. And we have presenters, Dr. Hollis Walker, who is a hematologist and oncologist, and Dr. Alicia Shelley. Okay, so we hope you can join us again next week. And again, we thank you so much for your participation.
Hello? Hello? Hello?
Yes.
Hello.
Good evening. I'm calling from Jamaica. My friend sent me the link, and it was a very informative meeting. I really enjoyed myself.
Thank you so much.
Last week I came on, but I couldn't get on, and I nearly never get on tonight because one of the number was wrong. And I had to go back into the Zoom thing that she sent me. And I would really miss a very interesting topic.
Very good. Thank you for that, ma'am.
Okay.
And,
All right.
we apologize again for that. Thank you so much. Okay, Marvin, you can go ahead.
Yeah, thank you very much again. Very special thank you to our panelists. You guys are fantastic, and we appreciate you being with us. And you're always invited to be with us, even if you're not a panelist. We have regular programs online. And by the way, we are a mission group. We typically go overseas, but of course, COVID has put a damper on those plans. So we are intent on serving locally as well. So we are serving the homeless, we're serving refugees. So there's a lot that we do, and we welcome any of you to be a part of whatever it is that we're doing. We hope that if you can support us financially, we'd like that. We appreciate that. But if you can support us with your time and your talents, we appreciate that as well.